Thank you. My name is Sophie Doran. I'm the Esophagogastric Cancer Fellow from Sheffield in the United Kingdom, and I'd like to thank SAGES and the committee for the opportunity to present our paper on the effects of pyloroplasty on clinical outcomes following esophagectomy. First of all, myself and my co-authors do not have any conflicts of interest to disclose. So, Ivor Lewis esophagectomy is the most commonly employed surgical approach for potentially curable esophageal carcinoma and gastroesophageal junctional carcinoma. But we all know that it's a complex, multi-step procedure, and although overall outcomes and survival from esophagectomies are improving, it still is a procedure with complication rates which are far higher than most other surgical procedures. And there's an increasing emphasis on improving post-operative outcomes following esophagectomy and also improving quality of life by minimizing post-operative complications. Pyloric intervention during esophagectomy. Now, the idea for this came historically from peptic ulcer surgery, and where patients had a vagotomy, they also had a pyloric drainage procedure. And this leads on to what is quite a controversial issue in esophageal surgery, that of whether pyloric intervention should be performed or not as part of an esophagectomy. The proponents of performing a pyloric drainage procedure during an esophagectomy argue that the high thoracic truncal vagotomy that's necessary for oncological quality during an esophagectomy leads to pyloric denervation, leading to gastric dysmotility, and ultimately leading to delayed gastric emptying with the associated consequences of a dilated gastric conduit, which can provide tension on the anastomosis, leading to leakage, aspiration pneumonia, reflux, leading to potential anastomotic strictures and weight loss. However, opponents of pyloric drainage procedures during an esophagectomy argue that delayed gastric emptying doesn't affect all patients. It may recover with time following surgery, and it also responds to endoscopic intervention. They also cite the risk of the intervention itself during the esophagectomy, and that it may contribute to increased operative time, and there may be long-term consequences such as bowel reflux. So, pyloric intervention during esophagectomy and the optimum management of the pylorus during an esophagectomy remains, I would say, a divisive issue in esophageal surgery. But there is a feeling that optimizing management of the pylorus may improve outcomes following an esophagectomy. And looking at the literature, there's also very little data on the outcomes for those patients who don't have pyloric intervention during an esophagectomy, but subsequently require post-operative intervention and what the outcome of this is. Which leads us to this aim of our study, which was to compare clinical outcomes, including weight loss, following an esophagectomy with or without a pyloroplasty. And the reason we chose pyloroplasty is, rather than the other possible pyloric interventions, is we consider it to be the gold standard procedure. And we also wanted to investigate the role of post-operative pyloric intervention. Now, this was a retrospective cohort study of all patients in our institution who had an Ivor Lewis esophagectomy over an 8-year period. And we divided our patients into 2 groups according to whether they had a pyloroplasty during the esophagectomy or not. We looked at the case series of 2 surgeons in our institution. One surgeon routinely performed a pyloroplasty and the other surgeon did not. We collected data on clinical outcomes, and we also collected data on the requirement for post-operative pyloric intervention, which was offered to patients who had signs or symptoms of delayed gastric emptying. In terms of our operative technique, we performed an Ivor Lewis esophagectomy with a standard 2-field lymphadenectomy. For those patients who had a pyloroplasty, a Heineken-Michelix pyloroplasty was performed. Every patient had a standardized circular stapled supraesophagus anastomosis, and they all had a standardized post-operative protocol, including the long-term uses of proton pump inhibitors. For those patients who had symptoms or signs of delayed gastric emptying post-operatively, they were offered endoscopic pyloric balloon dilatation. So in terms of the results of our study, our study included 207 patients. There were 92 patients in the group that did not have a pyloroplasty, and there were 115 patients in the group that had a pyloroplasty. In terms of patient demographics, there was no difference between the 2 groups in terms of gender, ASA grade, their preoperative weight, the neoadjuvant treatment that they had, we did find that there was a slight difference in the groups in terms of the age. There was a slightly lower median age in the pyloroplasty group, but looking at the data, we did not find that this was of great clinical significance. In terms of the tumour demographics, there was no difference between the two groups. So in terms of the tumour subtype, the T or N stage, and there was no difference in terms of the resection margin status. And of note in our series, there were no R1 longitudinal resections or R2 resections. So looking at the clinical outcomes we assessed, so we looked at mortality, so 30 and 90-day mortality. We looked at anastomotic leak rate. We looked at major respiratory complications, so Clavien-Dindo grade 3 and above. We also looked at anastomotic stricture rate. And finally, we assessed weight loss at the 1 and 2 year mark post-operatively. In order for the assessment of weight loss, we excluded patients who had disease recurrence or died prior to the 1 or 2 year time points. And comparing again the no pyloroplasty with the pyloroplasty group, we found there was no major difference in these clinical outcomes. I should also note at this point that there were no complications directly related to pyloroplasty for that group. Moving on to look at the requirement for post-operative pyloric intervention in the form of an endoscopic pyloric balloon dilatation, we found that 14.1% of patients in the group that did not have an intraoperative pyloroplasty required subsequent endoscopic intervention. And we found that a total of 21 endoscopic pyloric balloon dilatations were performed in 13 patients. It should be noted there were no patients in the pyloroplasty group who required subsequent endoscopic dilatation. We then performed a further subgroup analysis of the group of patients who did not have a pyloroplasty intraoperatively, so that was 92 patients. And then we compared the two groups, so the 79 patients who did not require an endoscopic dilatation postoperatively and the 13 patients that did. And in terms of the outcomes, we found there was no difference between these two groups in terms of mortality, anastomotic leak rate or anastomotic stricture rate. But importantly, we found that the group that did subsequently require an endoscopic dilatation had a far higher risk of major respiratory complications and also greater weight loss postoperatively. So just to reiterate those results, so for the patients who didn't have a pyloroplasty intraoperatively, 14.1% of those patients did require subsequent endoscopic intervention. And there was harm to this group of patients. They had excess weight loss and they had a far higher risk of major respiratory complications. So to summarize our results, we are presenting a large single center series assessing the impact of performing a pyloroplasty or not performing a pyloroplasty during an esophagectomy with an otherwise very standardized intraoperative and postoperative protocol. And we also assessed the role of endoscopic pyloric dilatation postoperatively for symptoms of delayed gastric emptying. We didn't find any major differences in clinical outcomes following esophagectomy, whether we did or didn't do a pyloroplasty. But importantly, we did find that over 14% of patients who didn't have a pyloroplasty required subsequent endoscopic intervention. And these patients had a far higher risk of respiratory complications and excess weight loss postoperatively. Now, what are the conclusions that we can draw from our study? Well, first of all, there was no major difference in terms of the outcomes between the two groups. And really, I would say this is the result that we expected. We believe that an esophagectomy is a highly complex, multivariable procedure, and it's far too simplistic to say that one simple part of what is a major procedure, such as pyloroplasty, can have a direct impact on clinical outcomes. Really, pyloroplasty is a small cog in the very complex machine that is an esophagectomy. And the overall outcome of an esophagectomy is based on so many factors, including patient selection, prehabilitation, the operative technique, and standardized postoperative protocols. But what we did find is that a proportion of patients who didn't have a pyloroplasty do come to some harm, even despite prompt pyloric intervention postoperatively. And the conclusion that we reach is that until the group of patients can be identified that will require pyloric intervention, it may be safer to offer pyloroplasty to all patients. Thank you for listening to the presentation.